I'm Doug Wood from the University of Washington in Seattle, and we're going to be talking about surgical treatments of mesothelioma with our panelists today. I'd like each of you to introduce yourself.
Franca Melfi from Pisa, University of Pisa, thoracic surgeon, and the future chair of the thoracic domain of EACTS.
I'm Lex Maat, Thorax Center, Erasmus University of Rotterdam. I'm leading the thoracic surgery program.
I'm Paul van Seel from the Antwerp University Hospital in Belgium. I'm the current chair of the thoracic domain of EACTS, and my role will be taken over at this meeting by Franca.
Thank you.
Very good. I'd like to start things off with the very basic question of a patient with limited stage mesothelioma, fit patient, no major comorbidities. What is your preferred treatment for that patient, Dr. Van Schil?
When the patient is in good general condition, we would now like to start with induction chemotherapy with cisplatin and pemetrexed. And then when it's feasible, we try to do we call it radical pleurectomy decortication, but I think it's the wrong term. We like to call it now extended pleurectomy decortication, meaning that you remove the parietal pleura, the visceral pleura, and if necessary, also the diaphragm and the pericardium, which can be reconstructed. So the main purpose of the surgical treatment, I think, is to obtain a macroscopic tumor clearance, meaning that less than 1 centimeter of tumor is remaining in the chest cavity. So we try to spare as much of the lung parenchyma if possible. On the other hand, when the tumor is invading the lung, in some cases, I think an extrapleural pneumonectomy is still indicated, although the MAS trial showed some very high mortality of this operation. But in fact, it was only on a very limited number of patients, so I don't think you can condemn EPP completely.
Thank you, and we'll certainly come back to the MARS trial as we talk about treatment, but I'd like to get Dr. Maat's opinion about your primary choice of therapies for early stage mesothelioma.
Yeah, my primary choice would also be an extended pleurectomy decortication. The thing we do not know is whether we should first give induction chemo or give adjuvant chemo. I get patients who haven't been treated with chemo, and I tend to operate them up front and then send them for adjuvant chemo, like the group in London from Guy's Hospital does. But I also get people who already got induction chemo, and then I do this operation. So this is one of the points we don't know, induction chemo or adjuvant chemo, and this will be a topic of the ERTC trial, which we are designing at the right moment.
Dr. Melfi, what's your preferred therapy for the early stage mesothelioma patient?
Our positioning is like the Paul van Schil. The first is absolutely an extended pleurectomy, but when it's possible, we avoid the induction therapy, and then we perform the extended pleurectomy and then the chemotherapy, the adjuvant chemotherapy. About the mesothelioma, when is to perform an extended pleurectomy is okay, but when we needed to remove the diaphragm, or we have the completely extended decortication, we didn't have a very good outcome in the patients. So we are reconsider this treatment, and we will see with the new outcome that we are studying, and we are coming in this period.
Thank you. Paul, you've been the main advocate for upfront chemotherapy of our panelists. What do you think the advantages are of induction chemotherapy before surgery?
We started with induction chemotherapy after the SAC Swiss trial, who showed some fairly good results when treating patients with induction chemotherapy. They started with cisplatin gemcitabine, and after we switched to the cisplatin pemetrexed after the Vogelsheim trial, and he had some fairly good results in obtaining microscopic tumor clearance, but by performing extrapleural pneumonectomy, followed by postoperative radiotherapy in those instances when there was some doubt about the radicality of the surgery. So that's the reason that we performed with the OTC a trial of induction chemotherapy, followed by extrapleural pneumonectomy and postoperative radiotherapy. And in fact, the primary endpoint of that study was success of that treatment. So the patient had to undergo the trimodality treatment and be alive without tumor recurrence 3 months after the end of treatment. But unfortunately, only 40% of patients had really what we call a success. So they had the trimodality treatment and were alive without recurrence 3 months after the operation. So in fact, this was a very tough treatment, very difficult treatment for our patients. And that's the reason that we shifted to induction treatment followed by plurectomy decortication. And that's the reason that also Lex mentioned that we are now trying to perform a trial of induction versus adjuvant treatment in mesothelioma patients.
And Lex, in what situations do you recommend adjuvant radiation therapy after your plurectomy decortication?
Well, I tend to recommend it, but the fact is we don't know whether it's good or not. There are many studies showing that radiotherapy doesn't do anything. There are also studies who tend to prove that radiotherapy is good. So it's a matter of believing or not believing. And I'm fighting all the day with my radiotherapists to get some radiation after extended plurectomy decortication, and they refuse it. But in other centers they will do. So this is still a question which is not solved.
And what do you think the difficulty is in delivering radiation in this setting also, which must be part of the reason that some of your radiation oncologists are reluctant to do adjuvant radiation therapy?
Well, I think it shouldn't be too difficult as you limit your radiation field to the surgical scars, the incision and the drain ports. It would be a much different item when you speak about hemothoracic radiation as was done after EPP, which is a really very, very big radiation field, high dose. This is a very, very heavy treatment for patients to undergo. And I spoke to several patients who were in our EOTC trial with chemo, EPP, and adjuvant radiotherapy, and said, "Oh, doc, if I had a choice between such an operation again or such a cycle of radiation, I'd choose the operation." It's really very, very tough. And be aware that in the 3-modality treatment in our study, we had quite strict time limits between all the treatment modalities. And then it took patients more than 6 months from the first cycle, from the first day of chemo till the last day of adjuvant radiotherapy. And they never came back to baseline. There's now a recent Italian study showing that, Mars showed it. Radiotherapy is, especially the high dose hemothorax is tough.
Franco, we've talked about the therapies. An important question for anyone is, how do we pick the right patients for aggressive therapy? So what are the strategies that you use for selecting patients for an aggressive multimodality therapy, staging or imaging, and what kind of routine tests do you like to do before embarking on aggressive treatment for localized mesothelioma?
The imaging, of course, the CT scan and the X-ray is basically all the imaging are used, and also the the PET scan. But basically we perform before decide the strategy, the therapeutic strategy. We use a thoracoscopy to be sure, of course, about the histology, about the stage of the disease, the mesothelioma, but also to check the situation inside in the chest to be sure that we are we have an early staging. In these cases, as I told you before, I select patients for surgery, and then we proceed with the decortication and okay.
And Lex, do you use PET scan routinely also?
Yes, we do. But despite all the high-tech imaging techniques we have today, you must realize that the disease in most cases is worse than you think. That's my opinion, that's Louis Klasdunsky from Guy's Hospital's opinion. And when you go to the Mars data, those 24 patients who were sent for EPP, they were reviewed by experts. And then after a long list of investigations, they were cleared for surgery. And then I think maybe in 2 of them, they were opened and closed because the disease was too far. And it's widely recognized that the IMRG criteria are not very sufficient to stage these patients. It's based on a surgical staging, but what we really desperately need is a pre-surgery staging, and we don't have the right tools to do that today. You could think that when you have a very hot PET scan with a high SUV, that means the tumor is very aggressive. There might be a chance that that would react better on chemo. We don't know.
Paul, do you use any invasive staging routinely? Do you do mediastinoscopy prior to choosing a patient for pleurectomy decortication? Do you do laparoscopy like some individuals propose to exclude any transdiaphragmatic involvement?
No, we are not used to do any laparoscopic evaluation before the operation. In case of doubt, sometimes we have performed MRI of the diaphragm, and as Lex mentioned, it's not always very accurate for staging, but we do a thoracoscopic evaluation beforehand. And mediastinoscopy is rather controversial. In the RTC study of the 3-modality treatment, it was an obligation to do a mediastinoscopy before the operation, and all the patients with N2 disease were excluded. But there are some recent data showing that pleurectomy decortication can be worthwhile in those patients, even with N2 disease. And the problem with mesothelioma is that most of the lymph nodes in the mediastinum that are involved are in the lower mediastinum. So lymph nodes 8 and 9, as much of the tumor remains at the costodiaphragmatic sinus, and those lymph nodes cannot be reached. And when you do a thorough evaluation of the lymph nodes, most of them that are involved are in the lower mediastinum and not in the upper mediastinum, in contrast to lung cancer. So we are used to do a mediastinoscopy, but have some reservation about the accuracy of it.
And you use it, do you consider that mediastinoscopy identified N2 disease is therefore a contraindication to proceeding to radical surgery, or is it just one step of your staging and it does not change your plan for treatment significantly?
Every patient is discussed with the oncologist in a multidisciplinary oncological board, and they consider it N2 disease as a contraindication, certainly for EPP. So we don't do any EPPs when you have proven N2 disease in the superior mediastinum. And for pleurectomy decortication, every patient is discussed, but we are doing it for those patients with N2 involvement. But then just pleurectomy decortication. Although it's difficult to know beforehand what you are doing, because as Lex mentioned, staging and especially restaging after induction chemotherapy is very difficult in mesothelioma patients. And I know in some institutions they are doing volumetric measurements of the tumor, but also that is rather difficult to perform in daily practice. And we have the modified RECIST criteria, but we know that they are also not very accurate at the present time.
And Frank, I'll bring up to question you about the other area that's often controversial about surgery, which is a sarcomatoid or mixed tumor, a mixed sarcomatoid and epithelial mesothelioma. In those situations, do you think there's a role for surgery, or in your institution, would those be considered contraindications for surgery?
Yeah, it is considered a contraindication for surgery in my institute, so we don't perform surgery in these cases.
And is that also true for you, Lex and Paul?
Yeah, for the sarcomatoid, yes, I wouldn't operate. For the mixed, I have very long talks with these patients in the outpatient clinic. I can easily talk with the patient and his family for an hour or longer and try to figure out how motivated or how is their condition, etc., etc., and then coming to an agreement with the patient. And I always start telling them there is no evidence for surgery in meso. It can help some patients who have a biologically slow-growing tumor in which the tumor growth is not affected by any intervention. It could be worthwhile, but we also know patients. I recently went to your colleague in Ghent. We did the first extended pleurectomy decortication in Ghent, and we had a beautiful microscopic clearance of a really stage 1 meso. And 4 weeks later, I mailed the surgeon, "How is your patient doing?" And he mailed back, "Don't be happy, he's dead." He got a massive acceleration of tumor growth, and he even couldn't make the adjuvant chemo. So that's another very important point. There is a large variety of biological tumor variability in mesothelioma. And we know some patients who can really do well after surgery, but in some patients we do harm with surgery. Patients should know that up front.
I want to tap into that comment that you make about your discussion with the patients, because I think this is something we all struggle with. And so tell me in a nutshell, what is the substance of what you tell the patient in terms of what the benefits are of aggressive multimodality therapy, and what the expectation is of how much difference that is going to make for them in terms of their length of life or their potential for longer term survival? That's always the question that patients have.
Yes.
They want to know, what would it be if I don't have therapy, and what would it be with therapy?
Yes.
What's the kind of summary of how you define that for
Yes.
patients?
You must take one thing in mind. That's, I have the general impression that the meso patient is better informed than the general lung cancer patient because they go on the internet. They have had many colleagues. Of course, it's an occupational disease. They had colleagues who already died of the disease, so I have the impression that they are better informed. But I sit with them, I said, okay, we don't know about surgery, whether it's going to lengthen your life or not. We used to do EPP, but we backed off. We think that for selected patients, pleurectomy decortication is better because there is a potential it could lengthen your life. There is, I think, absolutely a potential to improve the quality of your life, to get rid of pleural fluid, which is really a disaster when you have massive amounts of pleural fluids, and these patients can have liters of fluid. It ruins your life. So you have a chance of lengthening life. You have absolutely, I think, a big chance of getting a better quality of life. But the drawback is it's a big operation. Pleurectomy decortication needs 2 large thoracotomies at 2 levels to get rid of all tumor. You can have prolonged air leak. We see that often. You can get an infection. It can happen that you have to go back to theater for empyema or for bleeding. And then take the time to see how they respond. And then some patients, they deliberately chose not to be operated upon, not willing to have big surgery with an uncertain outcome.
Paul, how do you choose which patients should have extrapleural pneumonectomy? And now in the modern era, what % of your patients that you're doing surgery for are having extrapleural pneumonectomy versus pleurectomy decortication?
We try to include as many patients as possible in a trial, so to know more about the role of surgery, because we always have the ongoing discussion with the oncologist, and after the mouse trial especially, and probably we'll come back to that, that there is probably no role for surgery, they tell me. And on the other hand, a lot of patients are really desperate when they see me and they say, please, you're a surgeon, can you try to do something for me? And sometimes it's difficult to say no to a patient, but I always leave the option of EPP open to the patient. I say, we will try to do a pleurectomy decortication, but if it's necessary or your tumor is invading really the lung parenchyma and we cannot do a macroscopic clearance with a pleurectomy decortication, then we will go for EPP on the condition, of course, that the cardiopulmonary function of the patient is excellent and that he can tolerate that kind of operations. And most of them say to me, you're the surgeon and try to do really your best for me because I want to get rid of my tumor.
And what % of patients would you estimate are getting EPP?
I think it's a minority. It's 10 to 20%, I think.
And Frank, I was just going to ask you that very recently, EACTS with ESTS and the Society of Thoracic Surgeons did a survey of thoracic surgeon attitudes on surgical management of mesothelioma, and somewhat surprisingly, maybe not, that a majority of surgeons in both Europe and in North America felt both that extrapleural pneumonectomy and pleurectomy decortication had a significant chance of cure, and certainly a substantial majority felt that it prolonged life. You're taking over the thoracic domain of EACTS. I mean, what's the last word that you'd give us to close up our discussion about how you think we ought to be thinking about mesothelioma as thoracic surgeons and how we ought to educate our colleagues about the management of mesothelioma?
Oh yeah, we have to work a lot in this field, I think, because until now we have heard many opinions, and I think we need to know the real outcomes and especially to give the good guidelines or recommendations for the new generation. And at the moment, we need to know the real results, the real outcomes in this particular field. And so I will see, and I hope that Paul will give me the help, because I'm really, this is my first day that I know that the nominating committee decided to give this privilege to me. So I asked just before, a few minutes before, to Paul to help me in this very precious position, and I hope that Paul and you and all who have experience give me the support, and I can give the new generation the right indication and work together in a very good way.
Well, that's terrific. I have confidence that that will occur, and it's not just education for the new generation, but it's maybe even more education for the old generation to change attitudes about treatment of mesothelioma. But I want to thank all of our panelists for a good discussion about the surgical treatment of mesothelioma and your expertise, and I certainly have learned a lot from the three of you, and I hope it will affect how some of our colleagues treat patients in the future. Thank you.
Thank you.